So next up, I'm going to have Dr. Jerry Freed come up. Dr. Freed is a professor and chair of surgery at McGill University. You probably know him through the FLS project as well, and he's certainly been our sage for helping guide us through the development and validation of FES. And Dr. Freed is going to talk about the future of FES, linking to clinical performance requirements in surgery training.
Thank you, Brian and Jeff, and it really has been a privilege working with you on this project. It's sometimes a bit daunting to talk about the future, but it's something that's not yet even been implemented. But I think the issue of trying to link clinical performance with the FES program is important. And one of the things that struck me during one of the earlier talks is that it takes 100 flexible endoscopy, upper GI endoscopy cases to intubate the esophagus 90% of the time. What a waste of time and effort if it takes 100 efforts in the clinical environment just to get the scope into the esophagus. And if that's a metric of performance, then we have a problem. So there is actually room for us to come up with something a little bit better. I do not have any disclosures. What I'm going to try to kind of surmise about what the future opportunities are for FES. I will try to link it to clinical performance, and I think the speakers before me have really set the stage, particularly with respect to the work that has been done in gauges, which is now a metric of performance in the clinical environment, and then can talk a little bit about how this may fit in the whole process of surgical training. So our premise, I believe that all of us believe in, is that all surgical residents, and probably practicing GI surgeons and gastroenterologists, in fact, should be competent in flexible GI endoscopy. And that means not only competent in maneuvering the scope, but in the whole cognitive world with respect to endoscopy. So the question is, how do we define what competence is? And the next question is, how do we get there? So I think that John Mellinger really gave some very useful information about how competence is currently being defined. And the question is, if it was up to us to define competence, how might we want to do it? And then how can we come using that as a target with an educational process? So I'd like to talk about how we demonstrate competence now. So if you think about it, if you're a patient and you're going to undergo endoscopy, how do you choose the colonoscopist that you trust and that's going to do a good job for you? So I looked all over. I did a search on the internet, and I think I found a good example of this. And if we could run this video, please, with the sound.
Well, well, well. I thought we'd never get you in here.
Can we just hurry up and get this over with? Where's the doctor?
The doctor will be with you in a moment.
Is he any good?
He's the Michael Jordan of the colonoscope. I've seen him put one in from across the room.
Well, what kind of drugs are you guys giving me?
Oh, Dr. Rawls only uses one drug. No.
See this whole video. I have to show it to you after, just so the courtesy of time. But the point I'm trying to make here is that if we're the patients, and that is ultimately the constituency that we're trying to serve, how the patient defines competence is really important to us, and we have to pay attention to that. And you know, although this is done in jest, and I think it's really, really well done, actually, it's not whether the person did 50 cases or 75 cases. Is he going to hurt me? And exactly what's going to go on here. So we have to try to figure out a way of serving our public trust by demonstrating competence. So currently, it's done really by clinical exposure. So our surgical residents may undergo an endoscopy rotation, and they'll report the number of cases they've done. A proctor will assess them, and there may be some clinical performance indicators. All of these that John covered very well. That is, what is the rate of cannulation of the ampulla? What is the rate of cecal reaching the cecum? How many minutes does it take you to withdraw the scope, etc. These are clinical performance indicators, but in fact, that may give you information over a long period of time, actually after the person has been working for quite a bit of time. We don't have that as a way of providing formative information. So our goal really would be to come up with a formal validated test that really respects the goals that we're trying to achieve here, and to think about the perspective from the perspective of quality. And so we can look at actually evaluating people in the colonoscopy suite or the gastroscopy suite by having a trained evaluator perform a structured evaluation using an instrument that is reliable and valid, and that is really a good way of evaluating the technical aspects of performance. And gauges in itself, I think, has come a long way to providing some way of doing that people can attest is reliable and valid. It may have to be modified. There may be some other domains that we might want to add to in the future, but it's the first step, and I think it's a very good way of doing that. But it's not necessarily all that practical. It's hard to make sure that every individual that's doing the evaluation is doing it in exactly the same way, and therefore the best way of standardizing it is to do this in a simulation environment and a multimedia environment, looking at both the cognitive part and the hands-on part in a way in which every evaluation and every test is going to be conducted in the same way. Because the problem of doing it in the clinical environment is there's a lot of variability. Does that person have a very looped colon? Do they have diverticular disease? How do you control for all these things? This is something that we can do much better in the simulated environment. The other thing is the case numbers are unaudited. And we know that the volume is a surrogate for competence. It's not a measure of competence. And how do we know exactly how much responsibility the individual had in the cases that they're reporting? Were they completely autonomous? Were there verbal cues? Was there actually takeover or hands-on help that occurred? How do we know for the cases they're reporting how well they did it? So how do we combine both case numbers and quality? And we're not doing this very well. And we're not tying it to outcomes. And we have to recognize that every individual person, depending on their background and the other things that they do in their practice or in their training, will affect the learning curve and the case numbers that they'll require to be competent. So at the end of the day, the program director's sign-off is all that we've got to go on, and I would say that it's not very good. So as you heard, the goal of FES was to develop a curriculum that's standardized so that everybody's going to be evaluated according to the same rule. There's a cognitive set of skills, and there's a hands-on set of skills, and they've really been defined a priori. This is, although primarily a test environment, certainly the didactic component has got a very important educational value. And what we can do is, once we've got a test environment, we can then say that there's a whole series of options that people can use for training the hands-on part, and we have a gold standard against which we could measure those educational programs. So it's not going to require that everybody out there buys the Symbionics GI Mentor 2. It may be an excellent way for training people, but there may be other companies, there may be other ex vivo preparations that people could use. As long as we have a standard to measure them, then we can ensure the curriculum that we're using is actually an appropriate curriculum. So we have a standard. And at the end of the day, we have an objective and validated measure of knowledge and skills, and that we need to show that that's then predictive of clinical performance. So the future of FES is that once validated, we can have a standard for establishing competence in flexible GI endoscopy, and it could be independent of the route of training, and it doesn't make a difference whether the person's trained as a gastroenterologist or a surgeon. It will, as I said earlier, allow us to really assess how well we teach it and to keep upping the methodology of education. And it may allow us to answer a question that's been asked many times before, and that is, can a certain number of simulated cases in combination with clinical experience allow you to get to your goal more efficiently? Those of you that heard Dick Bell's talk, I believe it was yesterday, really set the question to us, how are we going to educate our people to a standard of proficiency within an 80-hour work week with all these competing interests? And so what we have to do is to set the bar appropriately. And we can tie certification and credentialing to proficiency, which is really our goal. So what we have to do next is to come up with a way of predicting saying really what the scores in the FES simulation and a test really imply in the clinical work. The other nice thing is that we may be able to use things like gauges as a method of assessing spheres of competence and struggles in the clinical environment, and then using that as a formative feedback that then directs the training process in a simulation environment. So we don't have to take 100 cases to get someone to intubate the esophagus. If that's really a problem, then we can come up with a simulated way of teaching someone how to do that. It could be very efficient. They could learn it in a half an hour rather than 50 hours standing around in the endoscopy suite. Okay, so in order to link FES to measures of clinical performance, we need to develop acceptable measures of clinical performance that we could all agree is standardized, so the same rules of the game to measure performance are used everywhere, that it's reliable, I spelt it wrong, sorry, valid, that the method that we're using for the assessment is practical and easy to apply. That's the nice thing about a global rating scale. And it needs to be sensitive to the type of differences that we feel are important, that need to be differentiated in our test. So if it just shows that a person who has done 10,000 endoscopies is different than a person who's never picked up an instrument, that's not a very sensitive test. And even though if you use those two groups as the basis for your construct validation studies, you're going to show a difference, it's not different enough with the sensitivity that we really require. We have to ask ourselves, what level of difference do we want to be able to detect? And then we have to evaluate our instrument with respect to those groups. And I think it's something that's often missed when people say, well, this is a validated instrument. And I think that gauges really will help us set that bar. So gauges, as you know, is a global rating scale. It's somewhat modified for both upper and lower endoscopy skills. It's got 5 domains in each of which are rated with 5-point Likert scales, with anchors that are quite descriptive of what a performance score of 1, 3, or 5 are for each of those domains. And it's really, if you remember, it's designed to evaluate fundamental skills. So this is a fundamental skill program that is the basis upon which we build expertise. So I think that that's important, and we have to define those goals. Again, you can't read this, but it's just the structure. The reason I'm showing this is that it really is quite easy to answer 5 questions. It doesn't take you a long period of time, and it provides an environment where actually you can provide, after the procedure, direct, immediate, and constructive feedback to the learner. And that in itself is a wonderful learning tool. So if we get a culture of taking a trainee after an endoscopy performance, and it's the same thing after an operation, and you sit down with them for 5 minutes, ask them to self-evaluate themselves, you self-evaluate, you evaluate them, you look at the concordance, it starts to allow people to develop insight, and it allows you to track their performance over time and actually show that they're improving. Gauges has now gone out there, and really thanks to Melina Vasiliou's leadership, it's been presented at the ASGE, SAGES, and the ASE, and will lead to 3 publications in this regard. And I think that's important because if this is an instrument that we really believe in, it's got to withstand peer review scrutiny, so that when we do these type of things, if we're going to get credibility in the program, we have to get it published in the literature. This is just a level of the inter-rater reliability. If you look at the line under ICC, that's the intra-class correlation coefficient, and that really is a reflection of the inter-rater concordance of the scores when they're administered by the attending and a trained evaluator. And they're really, really good for both upper and lower endoscopy. So you could really anchor this very well, and even though it's a subjective interpretation, the concordance in the scores can be really good. And you can see it really tells us a couple of things. One is that the difference between the groups, between novices and experts, although they're significant, they don't totally ceiling out. And that means that there is some room for improvement, and that's helpful in a test. Otherwise, if a person at a PGY2 gets a perfect score, it makes them feel that they don't have to practice anymore. The other interesting thing that Melina brought out, and she showed quite quickly, is that there is a way now that we could look at the discordant numbers that different societies are putting out as surrogates for competence and try to come up with a way of evaluating which of these is most appropriate as a measure or a reflection perhaps of performance in the context in which it's being used. So the numbers between, the differences between what internal medicine or ASGE use and, say, the surgical boards may reflect the difference in the group that they're evaluating. And it may be that there aren't going to be as many cases that are required for competence for surgeons that do laparoscopy, for instance, than there are for a naive internal medicine person. I'm not saying that's true, but we actually have a way of evaluating that, and we might see differences in learning curves for individuals and really show what our goals should be in terms of clinical experience. So gauges has become a gold standard to define proficiency, and the promise of FES is it's a way that we can assess competence in the various domains. It's uniform. It assists a breadth of attributes that we all have agreed upon are required for competence in flexible endoscopy. It needs to be a test that's standard to the type of differences that we want to be able to show. It needs to be predictive or correlate with clinical performance without risk to patients. And finally, the question is, will it meet the standards to be a prerequisite for certification, say at the American board level, as the FLS has been? So I hope that this has kind of wrapped things up, and look forward to the questions. Thank you very much.